Welcome. My name is Barbara Marcum. I'm a gerontologist and work with the City of Westland doing outreach and educational television. With me today is Dr. Akler from Akler Eye Center. Welcome.
Thank you so much for having me, Barb. It's a pleasure.
Well, it's my pleasure. We actually went out and did a show at Dr. Akler's office. It was wonderful, and that was about 10 years ago, so it's about time we do this again. We are going to talk today about a couple of different things. Number one is, as people get older, and being at the senior center for so long, I saw a lot of people go from 1.25, and as we get older, the cheaters get a little stronger. Why is that? And is that an age-related change?
That's a great question, Barb, and we get asked that all the time in the office, and I've had the opportunity now to experience it myself. As we age, the lens inside the eye gets stiffer and stiffer, and that is the reason that the vision up close gets blurrier, and we need the cheaters or over-the-counter reading glasses to help magnify the up-close whatever you're trying to look at to make it clearer. So it's a normal aging change. It is not a sign that something is wrong with the eyes, and we should expect the power to get higher the longer we all stay alive.
Yeah, some people, what age is there, like a specific magic age this happens? When does it usually occur? In the late 30s, around 40 and on, or is that
the average age is 40. Some people, it happens a little earlier. Some people do last a little longer, but it always feels like you've fallen off a cliff once, the near vision seems to go immediately. But really, it's been happening, it's been changing for years, and you just hit a wall and you realize that you need the glasses to see up close. The phone is just not clear anymore.
Well, one thing great is when you're hanging out with your friends, if you forget your glasses, it's, can I borrow yours? And it always works out really well. Okay, so I'd like to also talk about type 2 diabetes, because a lot of seniors, as they get older, develop type 2. They're more sedentary. So I'm curious how type 2 diabetes can affect the eye.
So diabetes affects typically the retina, which is the back of the eye. So if you look at our eye model here, this is the cornea and the lens are in the front of the eye. This is the retina here in the back of the eye. And with type 2 and type 1 diabetes, there can be hemorrhaging in the back of the eye. There can be swelling in what we call the macula, which is the center part of the back of the eye that we use to see fine details. So when you look to read, when you look at someone's face, you use your macula. And the commonest cause of visual loss in diabetics is swelling in the macula. Now, this is a treatable situation. So the really important message here is it's really important to have annual screening examinations to see if there are any diabetic changes in the eye, because there can be a lot of changes that you don't have any symptoms of, and it's important for us to know that so that we can prevent visual loss instead of having to go in and treat it when the horse is already out of the barn.
Right. Actually, can you see back behind the lens? What do you use to see back there?
So there's a couple of different things. In an eye examination, we dilate the pupil with eye drops, so it gets the iris, which is this part, the colored part of the eye, out of the way. It makes it large. Right. So that we can see through the pupil and examine directly the blood vessels in the back of the eye. It's actually the only part of the body where the blood vessels can be seen directly without a test. People are also screened these days, sometimes through their family doctor office, with fundus photos. So photos are taken of the retina and they're sent to a reading center, and that's it's a great test. But it doesn't replace the need for an eye examination, because we haven't checked the vision. You can't be screened for glaucoma that way. So even though that test is also terrific, we still recommend having an annual screening examination with an ophthalmologist to rule out diabetic eye disease and other common diseases that happen as we all age.
Yeah, typically people don't usually go to a doctor unless they are experiencing a symptom. If they haven't been going for a yearly eye exam, they really need to start doing that, regardless of what age they are. Is that right?
Correct. Mm-hmm. Yes.
Okay, so do you see, now let's jump real quick. I'm on a couple of things I want to talk about, but when you were talking about looking at the back of the eye, With macular degeneration, are you able to see the blood vessels back there? And is that what you look for when you're looking for macular?
Yes.
Okay, and what happens with macular? What's the difference between like age-related changes and macular degeneration?
So with macular degeneration, just from the name macular, it happens in the macula, which is the part of the back of the eye we were talking about that you use for your finest vision, so looking at faces and reading. And what happens with macular degeneration, initially there were some deposits of waste products, they're called drusen, in that macular area, and that is known as dry macular degeneration, the deposits, and there can be just some changes in the overall appearance of the back of the eye. And that can cause some visual loss. The more severe form is what you were alluding to, the wet macular degeneration. Abnormal blood vessels start to grow and they can start to leak blood and fluid and cause a very large and often a sort of rapid deterioration in the vision. The treatments for dry macular degeneration, we recommend a couple of things. One of them is to take ocular vitamins according to a study called the AREDS 2 formula. You can find them at any drugstore, big box store. We sell them at our office. It's a certain combination of vitamins that was shown in very large studies of people with at least intermediate level macular degeneration to reduce the chance of progression to the wet. So the vitamins are super important.
I was going to ask you that. Like Ocuvite and AREDS and all those different kinds.
Yes.
It doesn't matter which kind that you take?
It does not matter which kind. So you can look up what was recommended in the AREDS 2 study, and you'll see if you use Preservision, Ocuvite, store brand, as long as it matches that list of vitamins, they're all similar to each other.
Okay, and do you have to wait until maybe you get a diagnosis if you're younger, say in your 30s or something? Does it help to take those to make your eye a healthier eye?
So that's a great question, and we get asked that a lot at the office. It's not known whether taking the vitamins, if you don't have macular degeneration, prevents development of visual problems or macular degeneration. So what I tell people is, and often it's asked in the context of my mom has it, I don't want it, should I take these vitamins? I always tell them, listen, I don't know the answer. If it makes you happy to take the vitamins, there's not really a harm in doing it.
Right.
But really, all you need to do is eat a vitamin that's rich in antioxidants. That's what the vitamins are. So very pigmented fruits and vegetables, blueberries, kale, broccoli, collard greens, carrots.
Spinach,
like Popeye. If you eat a diet that's really strong in antioxidants, you probably don't need the vitamins. And even more important than that, if you're a smoker, stop. So there's a very strong association between smoking and the development of macular degeneration, as well as cataracts. So if you said to me, is there one thing that everybody should do, even if you don't want to take the vitamins, is stop smoking.
Okay, another question is the AMD, age-related macular degeneration, does that change as we get older? Is macular degeneration age-related?
Yes, it's more common as we all stay alive, as I like to say.
Yeah, because people are living longer and longer and longer. So yeah, that's something we probably all need to be concerned about. Okay, so after macular degeneration, we also have glaucoma. What is the way that you test for glaucoma and how common is it?
So glaucoma is another condition that is really common as we all stay alive. So all of these conditions we've been talking about, macular degeneration, glaucoma, the strongest association is advancing age. Now, there is an element of family history in there, so sometimes things do run in families, but just because someone in your family has it doesn't mean that you're 100% destined to get it. And what glaucoma is, it's a condition where the eye pressure is high, and it over time damages the nerves. This is the optic nerve in the back of the eye. It causes damage to the nerve and loss of your side vision. The screening test for glaucoma is having the eye pressure taken. And that at this time, it can really only be done in either an ophthalmologist's office or an optometrist's office. So when you go to get your glasses examination, the optometrist will also always measure the eye pressure as part of any routine vision examination.
What is normal eye pressure? What would that be?
So normal is between 10 and 21. millimeters of mercury. And then sort of borderline is 22 to 25. If it's over 25, even if there's no other evidence of glaucoma, it is recommended to treat that. So there have been some very large studies that have shown that having that high eye pressure, even without other signs of glaucoma, is a very strong risk factor for development of frank glaucoma over time.
Okay, when you say the pressure is something that needs to be measured, what would other signs of glaucoma be?
So here's the hard part. Okay. Most glaucoma, the open angle kind, which is by far the most common kind, there are no other symptoms until it's very advanced. So you wouldn't know that your eye pressure was high. The loss of the side vision is very subtle at the beginning. So if you are noticing that there's a loss of side vision, the disease is usually very advanced at that point. So again, the most important screening test is to have the eye pressure taken. In the same way that you don't know if you have high blood pressure unless it's taken, you have to have the eye pressure measured regularly to make sure you don't have it.
Okay, and you said, was it wide angle
glaucoma?
Open angle. Open angle. Yeah. What is the other kind?
So the other kind is closed angle glaucoma, and that is much more uncommon, but it causes a sudden, very severe increase in the pressure, and you would have symptoms. It's painful, it usually causes nausea and vomiting, eye pain, headache, and loss of vision. Like the vision becomes very blurry. So people know they have a problem and they seek care, and then we manage it. That kind is much more uncommon.
Interesting. My mom had glaucoma, my dad has macular, and so is there any genetic link to all of these eye things that we have? Obviously, if you need cheaters, that's a common thing, but with glaucoma and macular, it makes me worry because I have that kind of a thing on both sides. So is there a genetic link to that?
So the family history is relevant, so it does mean that you're at higher risk of developing these conditions, but it certainly doesn't mean that you will develop them. And again, it just goes back to make sure you have your routine eye examination. So if these conditions are developing and we catch them early, we can do our best together to reduce the risk of you having visual issues from them.
Okay, so now when we're talking about seeing somebody, and this is something serious and we need to think about who we're going to go see, okay, and why, what are the different doctors? There's an optician, an ophthalmologist. What are there are 3 different doctors that deal with the eyes, and then there are specialists like retinal specialists.
Right.
Okay, so who do you want to go see if you want everything checked?
Right, so an optician is a professional that manages glasses, basically, so they're not a doctor. The next thing is doctor of optometry, and then there's an ophthalmologist, which is what I am. So doctors of optometry go to optometry school for 4 years after undergraduate training, and they are trained to manage what's called refractive errors. So a lot of their time is spent managing prescribing glasses and contact lenses, and they do have experience diagnosing and managing diseases of the eye. Some are more comfortable doing that than others, but they are not either MD or DO, so they have not gone to medical school, and they do not do eye surgery. So ophthalmologists, we went to undergrad, we went to medical school, and then we did what's called a residency in ophthalmology, and we're trained to both manage medical conditions in the eye and also to perform laser surgery and incisional surgery of the eye.
Okay, speaking of surgery, the LASIK surgery. Everybody, what is that? What does it treat? And how is it done?
Okay, so LASIK surgery is a surgery designed for people who typically are younger and want to be free of their glasses and contact lenses. So for LASIK, you need to have a healthy eye, no eye diseases. And what it is it works on the cornea. So this is the cornea, it's the clear window on the front of the eye. And with LASIK, we make a partial thickness, it's called a flap, on the front part of the cornea. We reflect it out of the way, and then the excimer laser is used to reshape the cornea to correct the prescription. It's called the refractive error. And then the flap is laid back down, and people can typically see without their glasses and contacts. They can see clearly. Now, it does not fix the needing reading glasses situation as we age. Unfortunately, that is still an
issue. Yeah.
It is still a thing. So you cannot be glasses free for the rest of your life. doesn't work that way.
Okay, but does it treat nearsightedness and farsightedness?
It does. And
Oh, wow.
astigmatism also.
Okay. All right. So if somebody goes in and they're going in for their first eye exam that they haven't had any issues with their eyes, say they're 40-ish, what can they expect when they first go into the office?
So after they're checked in, and they'll be greeted by an ophthalmic technician. So that is a professional that is trained and skilled in doing initial examination and testing of the eye. They will have their vision checked with one eye separate and with both eyes together. We will check their pupils, the eye movements. This is, of course, after making sure that they don't have any symptoms that we need to address directly. They will have their eye pressure checked. And then they will receive drops to dilate the pupils so we can examine the retina in the back of the eye. And I definitely like to do that the first time I'm seeing someone so that we know we've done it.
So if they're going in and they've not had that done before, if you dilate the eye is important, they have somebody who drives them there.
For the first time, I think it is important because they won't appreciate how they're going to feel about their vision afterwards. People who are used to having their eyes dilated, a lot of them are comfortable driving afterwards if it's not a far distance. But for the first time, I think it is good to bring a helper.
Okay, now let's move on to cataracts. What are they and how do they form and what kind of treatment is there for cataracts?
So cataracts are another one of those conditions that gets more and more common as we all age. And we're back with our healthy eye here. So we talked about the cornea as the clear window on the front. The lens is inside the eye, and it's very clear when we're all young. As we age, the lens can begin to thicken and become opaque. And when that happens, we call it a cataract. It means a cloudiness of the lens. So in our examples here, the lens, instead of being clear, it grows cloudy like this. This is a pretty extreme example. So you can see as you look that the vision is not clear because the light can't get through to the back of the eye anymore.
Okay, so I mean, sometimes that you can actually see them, right? But is it just because as age-related changes happen that can people who are young get cataracts as
They
well?
can. It's less common, but cataracts can also happen from trauma, either to the eye or even to the head. Certain diseases are associated with early cataract formation, like diabetes, being on oral steroid medication, even inhaled steroid for asthma can predispose to the development of cataracts at a younger age. Also, sometimes it runs really strong in the family.
Well, that's really interesting because, okay, so then is it typical to have a cataract in one eye or in both eyes, or is there a variation of all of the?
Right, it can happen either way. It really depends on the cause. So most of the time, the cataracts that are associated with aging, which is still the most common kind, it's usually in both eyes, but it can be very what we call asymmetric, where one eye could be greatly affected and the other eye affected to a more minimal degree. But they're usually in both eyes. In a younger person, if it's from trauma or something, it could only be in the eye that was affected by the trauma, and the other eye could be perfect.
Okay, now as the cataracts develop, do people normally notice the changes, or is it very slow?
So at the beginning, usually people don't notice because you're right, they're usually very slow growing, but the symptoms are progressive blurring of the vision, so not being able to see things that you knew you could see in the past, maybe struggling with seeing street signs when you're driving, reading, seeing things on the cell phone, and also glare. So a lot of glare, again, it usually comes up with night driving, that the glare is almost incapacitating. So that's often due to cataract formation.
Okay, so when people have a cataract removed, how does that happen?
So we talked about the cataract being here inside the eye. So when we do cataract surgery, what that means is we're going to remove the cloudy lens and then we replace it. This is a special implant that's been measured for the eye. Of course, the real one is really tiny because our eye is not this big, and it goes right where the natural lens was sitting. It's been specially measured for each patient to focus the light on the back of the eye. And the surgery is done in an outpatient surgery center. You do get sedation, and you don't feel anything when we do it. It takes about 10 minutes, and it's done through very tiny incisions with special machines.
Wow. you would think, it would take a long time, but that's really a relatively short time to correct that, it seems. What is that made out of, the thing that's implanted behind it?
The majority of them that we use in the US are made out of acrylic. And they're flexible, so the way it goes into the eye, it doesn't look like this at the beginning. It's rolled up like a taco, and then we inject it into the eye, and it opens up inside the eye, and then we place it with these, I've got to put down my eye here, these little things called haptics spring out and hold it against the wall of the eye.
That's fascinating. What are all your other things here? You've got cataracts, then you have the implants.
I have a couple of implants, and this is a different kind of cataract. So this one's called a cortical cataract. It's more off to the side, and it looks like when you look at it that people are sticking their fingers into your vision. So this one causes a lot of glare.
Oh, that's interesting. Oh, and that's really nice that you can have some kind of model, because we don't know what behind the eye looks like.
Right.
So that's really fascinating. Okay, so when people go in to have the surgery, what I hear the most from people who have had it was, wow, I can't believe the colors. Because everything seems to be probably dimmed, with
as you can imagine, this is absorbing a lot of the light, and that's why the colors start looking washed out. So when you replace this with something very clear, everything looks vivid and bright again.
Wow, that's interesting. Okay, so now let's talk about, we'll skip back to macular. My dad goes for injections into his eye. What do the injections do? He hasn't lost any vision. In fact, when he went last time, they say actually his vision has improved, which was really surprising to me, because you think of that as a progressive thing. He was very excited. So when they get injections, what happens? What are they putting in there?
So with the wet form of macular degeneration, the injections are done in the office, and there's many different types of this medication, but basically they're all called anti-VEGF medications. And what they do is they counteract a growth factor that's circulating in the back of the eye that makes the eye grow these abnormal vessels. And the medication causes the blood vessels, in best case scenario, to shrivel up so they stop leaking. And when the fluid dries up, we always hope the vision will be better, but you're right, the basic goal is definitely to stop it from getting worse. And some people do experience improvement in the vision. Without the injections, the risk of it either not getting better or getting worse is very high. And I want to say that everybody, when we tell patients they need injections, every single person, yes, they do exactly like what you're doing. They open their eyes, they go like this.
Yeah,
they behave as if I told them I was going to cut their leg off in the office, and they're very terrified. And the truth is, it's very scary to think about, but the injection is done on the tiniest needle. The eye is numbed up. People really don't feel it. They usually just feel a little bit of pressure, and they see things floating around inside the eye, which is the medication afterwards. It is not as scary as people envision when they're told. So yeah, I don't want people to be scared to get it done if it's recommended. It's really necessary to be brave and get it taken care of.
Yeah, my dad said that it's basically the pressure that you feel. Yeah.
Yes.
Okay, I have another question, and this wasn't actually even in, last time we did the show at your office, it wasn't even a factor, but now that there are computers and phones, and people are constantly on their phone or on their computers more than ever, does this affect the eye at all?
So it does. It definitely causes eye strain, especially if you're looking at them a lot, and a lot of dry eye. So we do recommend that people try to look away from their device every 20 minutes, ideally out a window. And I know this show is really about our seniors, but there's a few different studies in our children that show that all this looking at screens, it increases their risk of developing nearsightedness. So really, for them, it's even more important. Of course, they're using them in school all the time, but it's really important for them to go play outside and not be looking at screens all the time.
Well, even though this is for seniors, a lot of seniors, well, we have a lot of people who watch it, and seniors are grandparents. So if you are in charge of your grandchildren and they're constantly on the computer, constantly on the phone, you might need to give a little bit of guidance there. Just for informational purposes, what is nearsightedness?
So that's when glasses are required to see clearly far away.
Mm-hmm. And you can develop that? That's just not something that you're born with? You can actually develop nearsightedness?
Yeah, absolutely, yes.
So what would you recommend as far as children being on their phones or, well, first of all, I don't recommend smartphones for kids below 18 myself, okay? But if the kids are on their phone or a computer, what is a reasonable time range for them to be able to get on and get off? Or is taking a break every so many minutes helpful?
Definitely taking a break. It's really hard in our society to tell any parent they can't have screens because, of course, first of all, they're using them at school. Second of all, they need them for their homework. Then there's the whole social aspect, and I'm sure our young teens would say that they need their iPad or whatever to communicate with their friends.
Yes.
But less is definitely more. I'm not here to police how people manage their children and their grandchildren, but especially the younger children outside.
Tablets as well?
The tablets are the same problem as phones. They need to not be looking so much up close. That's the idea. Okay. So natural light has been shown to reduce the risk of development of myopia. Not that being nearsighted is the end of the universe, but if you can avoid it, it does cause, it is related to some other eye problems as we age. So playing outside, super important.
Yeah, and the
not
play
done
aspect
as much
is
anymore.
social as well. Yeah, that's something.
Creativity,
yep.
Learning how to be bored. Now we're really diverging away from eye stuff. These are all really important things that I think our children don't get enough of with our society these days.
Well, psychologists are saying the same thing. So it's get them out and play, riding their bikes with their friends and developing those interpersonal communication skills. So we are off the topic, but okay, this has been wonderful. You are very informative. I thank you so much for coming in. I know a lot of people have questions, and I think you've answered everything very, very thoroughly. Thank you for coming in and spending your time today helping to educate the people of Westland, and I do appreciate that very much, so thank you again.
Oh, great. Thank you so much for having me. We're always pleased to do these educational programming, and I would love to see anybody at the office if they have very specific questions about their eye health or their diseases. We're at 2841 Monroe Street in Dearborn. We're at the corner of Outer Drive and Monroe Street.
Wonderful, and we'll post the phone number up there as well. Thank you again, and thank you, those of you in our viewing audience, for being with us today. I'm Barbara Marcum. This is Friendship Focus.